of all, I'm Carmela Petagna, so I'm with the Health Quality and Safety Commission. I manage a number of the quality improvement programs. One of them obviously has been reducing harm from falls, and I've had the pleasure with working and partnering with members of the sector, clinical leaders, and I suppose the important thing to note for me is that actually the manager and clinical partnership really is what's vitally important. That partnership is vitally important, which often in New Zealand we refer to as part of a governance model of in good hands. So this slide this afternoon, I've got my cross-agency hat on here, and we've really tried very hard for the Commission, the Accident Compensation Commission as well, and the Ministry of Health to work together. So it's a nice segue from what Sandy and what our other keynote speakers have been talking about. So that there is just an indication really of the three of us, and the logo Live Stronger for Longer is really what's come out of addressing some of the conversation today in the audience around why aren't we doing more in the community. We know that's where the evidence is strongest. We started in the hospital because there was an imperative to do that, but we always held a vision, and it's all about timing. We always had a vision that actually in time we would get to that community focus, and that's where we're headed now in New Zealand with a whole of system and cross-agency view. So I don't put the logos up there tritely, and I hope that those sitting in the sector can actually see that unified, coherent, logical message coming to you all, and we should all be able to sit up here and talk about what the Commission's doing, what ACC is doing, what the Ministry is doing. So we firmly believe that. And ACC have done some amazing work. They've been engaging across the sector, working as partners. This infograph or picture really depicts the circle in the centre there, or to your right, is really about keeping people independent and well at home. And there are many things we have to do to achieve that. And if we make a difference there, then actually we will be having a great impact on reducing acute demand on the health system and also on our aged residential care service providers. And I think the other two things, and it picks up on comments that both Francis and Lorraine have made about Don Berwick. You probably can't see it, but to the right, to one side, it says it uses words like, you know, what is the matter with you, and we're shifting that into being more positively framed, which is what matters to you. So that really again resonates and picks up on how important it is to address an individual's need. What's really important, as I and others have been working with ACC and the Ministry of Health, is that we've been really embedded in understanding what's important to the patient and the family and whānau. So we have this character we have called Muriel. Actually, she is someone's mother from one of the teams that we're working with. And so really this is about valuing older people as part of society and the contribution they make. Holding people at the centre of everything we've done in the cross-agency work has been very, very real. And to do that, I'm going to show you a little video clip shortly. It's really understanding what our perception is of older people, what their aspirations and goals are, and how we actually respond in terms of what we're trying to do in the community about increasing strength and balance programs, keeping people well, socially engaged, independence at home. So ACC have funded a bit of research and focus groups, and the findings I found really enlightening. So I'm going to play those to you very shortly. The thing that has driven us all, I suppose, is that for ACC, if you think of what drives them, the fall is an injury, and it's a claim, and it's dollars. You know, and so they've got this incredibly increasing trend which is not sustainable. If you think about the health system, we've talked about it this morning, it's a trigger, it's a marker of something much bigger than just the fall. So it's frailty, and with that obviously comes demand on the system. And for the older person, it's actually life-changing. It's a loss of independence, and so our challenge, as we've all said, is actually to avoid the fall and avoid the fractures. And as Sandy said, that means actually addressing some really downstream or upstream, I always get it wrong, but you know, really looking at bone health and what we can do to help that. And that's part of the system change. So I'm going to play a little clip.
On my driver's licence it says that I'm 74.
I'm 64.
Very nearly 75.
I'm 79.
80.
76. I feel about 50, 55.
Sometimes I feel about 90, and another time I might feel about 50. And I was pretty active at 50.
Feel more like I'm in my mid-50s. But sadly, that's the age of my sons.
Oh, wow. Mentally, I'm still around 30.
I could feel about 100 on some days, and other days when people ask me, how old am I? And I say 80, and they say, oh, I thought you were 70. So that's very complimentary.
About 25? Oh, 26, sorry. I'll admit to a little bit older.
Public perception is that I'm a how are you darling type person.
The frustration is that people call you dear, and I don't want to be called dear. I'm not that old yet.
And they think because you're old you must be mentally deficient, perhaps.
It's when middle-aged women stand up for me in the bus that I feel that there must be something different.
I relate to them in the sense that I know this is coming.
No, not at the moment anyway.
It sort of worries me a bit, feel a bit, I don't want to be that old.
No, I don't associate me being of that age.
Not that inspired really, but more I felt sorry for them because I don't see myself as being like that. Yes, the word independence straight away would captivate me, very much so.
I probably would, yes. I read anything really, if I can prevent it.
Yes, I would be interested because I want to keep independent.
Yes, that looks fascinating because you've got words, you've got a person and some scenery. And I love the red gumboots.
Well, she looks like she might be gardening, and because I like gardening, yes, I would certainly look at that brochure.
Yeah, that's better than those old fuddy-duddy geriatric types that were on the earlier one. I have a problem believing that I need to go.
Yes, I would, because it's quite nice to meet other people and do those activities.
Well, I'd go along and see how they were, to get the experience.
There's wonderful exercise classes, but as they involve standing up and dancing, etc., I found the pool was easier for me to cope with.
But maybe if there was afternoon tea and scones, I could be tempted.
Okay, so I guess that sort of gives you an example of the challenges, I suppose, and how we historically perhaps have responded in not a way that actually resonates with the audience we need to attract. So the cross-agency work is vitally important. They are ACC. I shouldn't keep saying they, because we are really collectively working in this together. And so there's been a whole suite of resources. There's a new website established, which I'll talk a little bit more about as I go through the presentation. So the Live Stronger, Live Longer, with themes around independence, hips, bone strength, is resonating very well with those we need to connect with. Picking up on Sandy, where Sandy finished off, I guess the point for us at the Commission is that actually we all know we can't take our eye off the issue in hospital and in the acute care setting, but what we are now supporting in a leadership role is how we move our attention into the broader community area. And ACC really has come to the party and is committed to, as the slide says, creating alliances, making a contribution. Many of you will know that they've actually injected quite a sizable amount of funding over 3 years. It won't be there forever. It is only seed funding, it's an injection, it's a partnership, And what we're hoping, I guess, long term is that as we measure our outcomes across the system, then actually that becomes self-fulfilling and engages leaders and organisations to continue the commitment, because it's going to take quite some years to shift the trend. The cross-agency work here, I guess I don't have to read all the detail there, but Sandy did touch on the fact that we have had a big focus for the last 4 to 5 years. We have made a difference with the sector. We haven't, actually it's been the sector has made the difference. We've just provided an impetus and a spotlight, and we will stay there holding certain things. One of the things the Commission will hold is the evidence review, the monitoring, the intelligent commentary, and partnering with agencies such as ACC and the Ministry. One of the other things that for New Zealand, the Ministry of Health is promoting, and I'm assuming some of you have heard this, you've all heard of system level measures. Is that familiar to some of you? If it's not, it should be. What's happening is actually the Ministry is promoting system level measures, so you have an ability at your local area to be looking at what contributes to those, and they are things like reduced hospital bed days, reduced admissions, improved recovery. So that falls, and fracture prevention plays into that very, very nicely. So we're trying to align some of the monitoring to what is important for all partners in the system. So we'll go quickly into looking at what the component parts are of the system that we're looking at, and then I'll show you a pictorial view of sort of the outcome framework we're looking at putting together, and the Commission has a role in helping develop that, which is where our strengths are. So as we said, the key one is wellness, keep staying at home well and independent, and in there we've got both in-home, strength and balance, and also community-based programs. The fracture liaison services are an integral part around coordinating, and I think Sandy and others have touched on, we can't look at just the hospital journey, it's what comes before and actually what goes after. So both fracture liaison services I personally think are really important at both ends of that. Early supported discharge, we're looking at some really innovative work here around evidence tells us actually that keeping people in hospital for long periods of time is not potentially where the best recovery and rehab is done. It should be done in their place of home, whether that's the home care facility or at their individual home. But actually the funding in the system is not geared up to do that. So it's about, we're doing some work at looking at different case mixes, and I'll talk a little bit about that in a minute. So the whole of system approach really has been that central agencies are coming together. We are looking at, as I said, a framework that sits across the system, and there are 5 key areas we're going to look at, and that means that everyone who's participating in their particular area of expertise can actually look at where they sit in the bigger picture. The benefits to the health system, less than predicted claims, that's really particularly for ACC. Fewer admissions to hospital and aged care we've touched on, that's really looking at how we manage that demand with an ageing population. And for the older person, which is the most important, that's the improved quality of life and independence, which we hope we will achieve by doing all that we've got planned ahead. This is not new, I'm sure, to any of you, I guess. We've been really focused at that acute end with the fractured NOFs that we've been looking at, with clinical treatment and interventions, and what we're doing now is moving up that triangle and looking at the more well old and well at home and how we focus on that area. The fracture liaison service, I guess, as we know, is about identifying what some people have called those trigger events, those herald falls. So how do you go about connecting and engaging and identifying those people at risk early, and how that feeds into what interventions you put in place for them? Bisphosphonates is one. The other area, of course, is what are we doing around improving bone strength and screening for that in a primary care setting or in a GP practice. This is the area we talked about with early support to discharge. ACC are actually leading some work in there. There are 3 district health boards that we're working with, Auckland, Waikato and Canterbury. It's a 12-month trial that's going to be taking place, and it will be independently evaluated. And I think Michaela, if she's still here, took your note about keeping the signals alive, and I suppose this was part of that. At all of those transition points, what are we all doing that makes sure that the information about the individual transfers with that person through the health system and on their journey? Strength and balance and exercise programs has been spoken about a lot. New Zealand obviously has led the way with the Otago exercise program, and that, as we've all said, is the gold-plated program and been adapted in different ways in different jurisdictions. The same principles have been applied here, and we've had in-home program. The in-home program is resource intensive, which we know, but the evidence base says that that can reduce falls by up to 30%, and that really is historically delivered by clinicians such as physios. So it is resource intensive, but that is what is being proposed and adopted. But we do know that it's not suitable for people in rest home and hospital care, and I do feel for some that are sitting in the audience from aged residential care facilities, because I don't feel that we've really targeted anything specific in aged residential care, but the Commission itself is picking up another piece of work for aged residential care, so hopefully we can weave some of this work in there. We're focused on the hospital, we're focused out in the community, but there is something about aged residential care that we really do need to focus on as well. So community strength and balance, you'll see the tick in the right hand corner there. I mean, it is a way that across agency we're saying, actually, how do we make sure that programs and service providers that are delivering strength and balance programs are doing it in the right way? So there are some criteria that have been established by technical advisory groups, both for in-home programs and also for community-based programs, and we're thinking this might be a little bit likened to the heart tick, to say, actually, if you're meeting all of these criteria and you've got a structure in place that supports it, then consumers and individuals, when they're looking for a provider and a deliverer of services, know that that's like an assurance tick to say, yes, that is a safe one that I can go to. That's really looking at Muriel really at the centre of everything we do, and that really underpins the whole of system view in terms of starting in primary care, look at what we're doing in that community environment, looking at secondary prevention and rehabilitation work, vitamin D and safe mobilising, probably in medication review is what's particularly relevant in aged residential care, and all the while keeping Muriel at the heart of everything we do, so what's important to our loved ones. The boxes at the bottom I'll go to in a minute, but they are really some of the system pieces that are important. We've touched on the hip fracture registry, we've partnered with Australia. Implementation this year in New Zealand's really going really well. We're looking that all public hospitals will implement that, but collecting data and making that as robust as possible will take a wee while, but we're doing quite well this year. The criteria we've spoken about, guidelines with osteoporosis, and most of all the website that's been established with community resources. I won't dwell on that too much, but it is important to recognise some of the partners in the room. So Aged Concern, ambulance, aged care providers, they've all been sitting around various national advisory group tables when we've been speaking about how we address falls and fracture prevention and management in New Zealand from a system view. So all very, very important players. And I know that ambulance services have done some great work and adapted even some of the work the Commission's done around educating staff who are going into homes. I know from the work Sandy's done in Wanganui that amazing reports are done and shared around what the population and call-outs look like related to a fall. So we have government agencies working together. All of this work sits under a cross-agency alliance group, and sitting at that table are managers and senior executives from the Commission, from ACC, from the Ministry of Health, funding and planning. So the outcome framework is something that we've been working on together. The Commission, through the next 12 months, will be developing some of the indicators that are in here. So we'll talk a little bit about that. The visual, I think, is really important. Where we aim to get to is that at the moment we've issued 2 reports. We call them flat file reports because they are really what you see is what you get. But over the next 12 months, our health quality and evaluation team are going to look at turning this into an interactive dashboard. So DHBs will be able to see their own data. They'll be able to benchmark how they're doing against national data, and it will come out every quarter. So it's going to be very, very useful for people to use for local improvement and use it for their own reporting within their local organisations. And planning and funding as well. So there are 5, I don't know how clear that is, but there are 5 key domains, and I guess the central one is the independent well at home. Now the areas where the measures are going to be really important, and this comes back to system level, is we'll be looking for fewer falls injuries. That's really important to us all. Fewer serious harm falls and fractures. Improved recovery, and that's in hospital and at home, and what is it that's going to happen to help us get there. And then integrated falls and fracture care across the system. So that's the 5 domains, and within those we'll be looking at picking out indicators and measures from existing data sources. This is not about increasing the burden of data collection, and we touched this morning on, how much do you measure? And but these domains are considered to be the 5 key ones, and there'll be key indicators against those which we can track over time. So this is just an example. I'm going to whisk through these, I won't spend too much time, but this is an example of some of the graphs, but they will be improved so that they can be interrogated. So this is one that comes from ACC claims data. And actually it's interesting that, there is the orange line. The orange line obviously shows already a slight softening, but we can't get too excited about that, because I do think that some of that comes down to coding of data within ACC itself, so that is being looked at in a bit more detail. The next one again is ACC claims, and I guess the challenge is measuring metrics with an ageing population projection. But if the approaches get traction, then we should see a decline over time. So there we're measuring the numbers and the rates, obviously, of fractures and non-fractures. This one here is really interesting, and this is obviously showing again fractures, non-fractures and other. And you can see, there is a line through that presentation which probably is a bit premature. It probably shouldn't be there, because I think it's far too early to do that. But if you looked at it from a naive eye, you'd say actually there is a slightly decreasing trend. And I guess everyone has been working in the falls and fracture space now for 5-6 years and beyond. So there's a raised profile, and you'd like to think actually that some of the work we have done in our focus on fractured NOFs has had, we can't claim attribution for that, but you'd say there has been an increased awareness of what has hopefully impacting on a reduction. This is another really important one, I suppose, and it links to the previous slide, because I guess it depicts why it's so important to reduce the demand from fractures and fractured NOFs, because they account actually for a significant share of hospital bed days when you look at them by type, and it's actually where the highest cost demand is. This again is taken from National Minimum Data Set and links to our Atlas of Healthcare Variation. It's reasonably static, but it is something that we need to be looking at, and it is also one of the metrics, I think, Lorraine, that's picked up in the hip fracture registry. So like your comment about early mobilising, this one here is also very, very important, and there's still 76, there's still a lot of room for improvement there. This is an example. I think many of you have picked up some of the booklets and some of the resources that have been put out by ACC. There's a wealth of data there and more. This is being promoted obviously across the country. There's a website that's been set up particularly for individuals and healthcare, people who are caring for older people and health professionals as well. So that's an example of some of the resources available. Shared resources, that really indicates how we've tried to pull things together. So there you'll see the new 10 topics that, as Sandy mentioned, we've recently updated based on an evidence review as well. And as other speakers have said, the evidence doesn't change rapidly. So we plan to do this every 3 years. The Stay Independent Toolkit is something we put together for primary care. And so to help some of those early conversations and engagement points in GP practice. And you'll see there's work from Osteoporosis New Zealand, around care guidelines and algorithms, and also ACC. So we are trying to pull that together in one umbrella. In terms of reach, ACC, as part of the work they've been doing, have been engaging and contracting with lead agencies across the country, and I think that they've nearly completed coverage across New Zealand. So they will be tasked with engaging with local falls groups. They need to be integrated across hospital and community, and their prime driver really is to look at how they spread their reach, how they get people into appropriate exercise programs, whether at home, delivered at home, or in the community, and how we monitor the effectiveness and that will also be evaluated. Some of the lead providers are Age Concern, I think, in some areas. Some are Sports Trust. In some areas we've got pharmacy clinical networks. So it is bringing people together across the continuum. That's the website, livestronger.org.nz. There is resources there, as I said, for individuals, family whānau, health professionals, educators. And there's also in there, picking up on Lorraine's comment, there is a map that's early days, but we're building on that, and that you'll be able to hover over it, and you'll be able to identify as things develop which people are able to deliver programs in that area. So I think that's something that we've not had in New Zealand for a long time, and you do it well in New South Wales. So I suppose in summary, the key things are we have really tried to work hard at common goals and looked at perspectives across the system. We've tried to align activities, so we're not going out to the sector with incoherent messages, so we've tried to align activities and efforts nationally and locally. We're going to measure outcomes together, so we all have a part to play in that, and that will help us with those conversations in terms of leadership within our respective organisations, and we need to work at multiple levels. So I guess in closing, really, I just want to say thank you to, first of all the partners, but most importantly, really, it's a recognition of the sector and all the work that you're all doing, because actually everything we do, we help, but actually we're only a partner. None of it would be possible without the passion, commitment and engagement from everyone in the room. So on that note, I want to say thank you to you all, and I hope you've all had some great take-home messages and get something out of today. That's it.